Hello friends, welcome to ICU Simplified. Today we are going to discuss how to recognize and classify different types of shocks. Two patients walk into your ICU, both hypertensive. You start fluids. One improves, the other spirals down. Why? Because recognizing the type of shock isn't optional, it's life-saving. Shock isn't just about the blood pressure on the monitor. It's about tissue perfusion, cellular oxygen, and organ survival. Let's break it down the ICU way. Shock means your tissues are starving for oxygen. To treat it right, you have got to know what's going wrong. We classify shock by its root problem. Distributive, that's vasodilation gone wild. Hypovolemic, that's tanks empty. Obstructive, something is blocking the flow. Cardiogenic, the engine is failing. Each type, a different approach, a different outcome. Here's a trick to remember it all. DHOC, distributive, leaky wide open pipes. Hypovolemic, an empty tank. Obstructive, blocked pipes. Cardiogenic, a failing pump. Diagnose right, treat smart, save lives. Let's line them up side by side because the details matter. Skin clues, JVP, fluid response. Each one whispers the truth if you know how to listen. So in hypovolemic shock, it's due to volume loss, skin will be cold, JVP will be low, and it will improve with fluids. In cardiogenic, there's pump failure. Again, skin will be cold, but JVP will be high, and it's going to worsen with fluids. Distributive has a vasodilatation or leak, and this will lead to warm skin and with normal or low JVP but no response or partial response to fluids. In obstructive, there is obstruction, skin will be cold, JVP will be high, and there will be no response to fluids. Trauma, think hypovolemia, warm skin, low JVP, could be sepsis. Fluids making it worse, that's cardiogenic, no response and raised JVP. You are staring at obstruction. This is pattern recognition with lives at stake. Echo doesn't just confirm, it clarifies. Let's decode it. Hypovolemic, collapsed IVC, hyperdynamic heart. Cardiogenic, sluggish LV, reduced contractility. Distributive, often high output but the tank still leaks. Obstructive, depends, is it a PE, a tamponade, a tension pneumothorax. Each has its echo fingerprint. Let's learn to read it. So in hypovolemic, there is small underfilled LV, collapsible IVC. In cardiogenic, LV contractility is poor, dilated LV, and possible MR. Distributive, hypodynamic LV early, normal or high ejection fraction, IVC is collapsible. In obstructive, it's PE, dilated IRV, septal shape, that's D sign, McConnell sign positive. If it's tamponade, then pericardial effusion, diastolic area RV collapse. In PT, there is poor filling, RV compression, and mediastinal shift. Anchor it with classic examples: hypovolemia, trauma, hemorrhage or diarrhea. Cardiogenic, MI, myocarditis, lethal arrhythmias. Distributive, sepsis, anaphylaxis, neurogenic crash. Obstructive, pulmonary embolism, tamponade, or that deadly tension pneumo. Know these cold, your patient doesn't have time for hesitation. Spotting shock takes more than machines. It takes a clinical eye. Tachycardia, low BP, though sometimes it tricks you. Colder, warm skin, fluid response, JVP, lung sounds, and your stethoscope's whisper. Medicine is pattern recognition. Shock is no exception. Your clinical eye is your best tool. Here's a quick challenge. A 30-year-old trauma patient, blood pressure 80/50, cold hands, flat JVP. You give fluids and BP bounces back. What kind of shock are you dealing with? Drop your answer in the comments and let's test your instincts. Still confused at the bedside? Use this roadmap. You should start from hypotension, and then you should look for the skin if it's cold or warm. Check the JVP at the same time, and then simultaneously try fluids. Echo will confirm what your gut already suspects. The signs are all there if you know where to look. So if there is a patient with hypotension, you have to go for the skin temperature. If it's cold or if it's warm, you know, if it's warm, then it might be distributive, that is sepsis or anaphylaxis. JVP if it's low hypovolemic, and there will be relevant history of bleeding, dehydration. Cardiogenic JVP will be high, in obstructive JVP will be high. Then we'll go to echo after if JVP is high. Again, trying fluid simultaneously. If it improves, it's hypovolemia. If it doesn't, then cardiogenic or obstructive. Echo, poor LV is cardiogenic, dilated RV is PE, and tamponade is pericardial effusion. There are all the clues there. You just have to look for them. Let's tie it all together. Shock is perfusion failure. 4 types, 4 treatment paths. Skin temperature, JVP, and fluid response. You are best friends. Time is tissue. Every second counts. Act fast. Want ICU content simplified but powerful? Subscribe to ICU Simplified. Up next, septic shock, like you have never seen before. Like, comment, and share this with your ICU crew. Let's learn, let's save together. Thank you so much. Take care. Bye bye.